here today. I've certainly been hearing a lot of buzz about Project Echo, and it's lovely to be able to connect in here, and also on a topic that I'm very passionate about, and hopefully we'll have a good discussion as part of this. So I will get moving along here so that we can get to the good part of talking together. These are the disclosures. I don't have any financial conflicts of interest to note. I am involved with the Fountain of Health Association, with a not-for-profit. So there's no financial support, and I'm not going to talk about pharmaceuticals, and I haven't received any payment from the Fountain of Health, although I will refer to some of the materials that you can find for free on the website. And I'll leave this for you to all have a look at, but the program and the materials are peer reviewed. And so the recommendations that come from ECHO talks conform with generally accepted standards. I also just want to take a second to acknowledge the involvement and support of a number of organizations and people, particularly Dallas and I have worked closely together through the Canadian Academy of Geriatric Psychiatry, that has been a close supporter, involved, and partner in this work, as well as the Canadian Coalition for Seniors Mental Health with Claire Checklin and David Kahn and Kieran Rabaroo, and other collaborators include Dr. Michael Vallis, who's a psychologist and founder of the Behavior Change Institute. So I've been delighted to work with him. Beverly Cassidy, who has collaborated closely with me, and particularly around some of the clinical tools in the wellness app. And Dr. Cindy Grief at Baycrest, who I believe may have been the person to invite me into this talk, but we share a lot of I think I may have some of her slides in here, so I just have to give her due credit here. But we, all of us work pretty closely together in giving talks and have shared each other's slides through various conferences over the last number of years. The hope is, after the talk, this brief introduction today, that you'll be able to define mental health and resilience, as well as know key promoters of mental health and well-being. And you'll have a sense of how to access some key resources that will support mental health and wellness. So I'm going to just ask the question, and actually, if you don't mind to put it into chat, what do we mean by mental health? If anyone could venture to guess that very briefly. And Dallas, let me know what people say. When you hear the word mental health, what do you think of? Or Dallas, you could share what you think of.
So we have contentment has come up. Okay. Emotional and psychological well-being. Okay. Sense of well-being, overall well-being.
Right. Great. And so people are talking about this, this term, I think, given the title of the talk. But in our day-to-day work, is it not the case that we conflate the word mental health and illness all the time? We talk about come to the mental health clinic, but generally what we're talking about is the diagnosis and the treatment of illness in the day-to-day lexicon. And so that I just wanted to put that out there, because as long as we continue to use mental health as a euphemism for mental illness in our day-to-day work, it makes it a little difficult to actually grasp, define, and work on what we actually mean by mental health. So it's a little bit of a conundrum that, while in our effort to make mental illness more something that has less stigma and more accessible to our services, that we also potentially do a disservice to really taking careful attention to mental health. So mental health, as people are alluding to, is about a state of well-being. This is the World Health Organization's definition. But our goals with our mental health is that we can reach our full potential, that we can cope with the stresses of day-to-day life, that we can work productively and fruitfully, and that we're making contributions to our community. And often when we see people in our mental health clinics, It's about trying to help bring them back from a state of deficit in these areas that, you know, by definition, they're having problems in their functioning, and you're trying to help improve the functioning back to at least a baseline. So what it doesn't though do is add in our model, it doesn't really add for the scope of how to improve beyond a baseline. And I just wanted to just raise this as an issue. The other point is that many of you will be familiar with the bidimensional model of mental health, mental illness, that you can have good mental health without a mental illness, but you can also have good mental health with a mental illness. And then the other two, you know, quadrants are also possible. And so in our minds as clinicians, it's helpful to really separate the two terms, the two concepts, and realize they can coexist. The term resilience also gets bandied about an awful lot and means different things to, you know, pretty much everybody. There's a colloquial sense, but the research sense is really important to know what does this mean? And so at an individual level, yes, it would be like being able to grow in the face of adversity. But a more nuanced definition comes from our Canada Research Chair in Resilience, who's Adele. It's kind of more ecological. It's kind of the environment in which we find ourselves and how we navigate and negotiate the resources that we need to sustain our well-being. Like this poor little plant that's really, you know, in a hard way has somehow managed to eke out some life and is doing quite well. Thank you very much. And similarly, you know, patients who have significant chronic mental illness, you know, may have significant vulnerabilities, significant adversity, and we're hoping to see them thrive in the face of that adversity. So I just like to offer up this model, which comes from Volkman and Greer, on how to promote active coping or thriving or you know, becoming a more resilient in the face of adversity. So that means that there needs to be a threat. There needs to be a problem. There needs to be some sort of adversity. And so our patients have that. They come to us with that. And so there's a real opportunity here to think about this in a more evidence-based way. So what do we mean by that? You're welcome to watch this short video that's on the link there if you wish, but I've tried to summarize it in these three circles, and I'm going to touch on each one. That there are behavioral things we can do, interpersonal things we can do, and cognitive things that we can do that promote our well-being. And this is a kind of an evidence-based model. What do we mean by cognitive things that we can do in the face of a problem? Our thoughts, as many of you would be familiar with, can be changed. They're plastic. We tend to think if we think something, it must be a fact, it must be a reality, when actually, it all depends on perspective, and you can change your perspective. And it's this premise that cognitive behavior therapy is based on as an approach. Our goal in CBT is to notice our thoughts, figure out which ones are helping, which ones are not so adaptive, and try to align these and balance these in order to reduce symptoms, relapse, but also improve our happiness, our function, and our resilience. So you can come up with more adaptive ways to think in the face of adversity. So as an example, if you think about aging as a really bad idea, I'm about 50, I just turned 50, I'm over the hill. Why bother? We all know it's downhill after that, don't we? It's so it says on all the Hallmark cards. So we might end up being more sedentary. I'm middle-aged now. Exercise is for the people in their 20s. So if, however, my thought is that I have a lot of plans, I'm planning to get to Machu Picchu, sometime in the next 10 years. So I'm going to get out for walks. I've got something in my mind as a future goal. So you can see the impact of the thought on your behavior, but it goes the other way around. You can just start to activate your behaviors and end up shifting your thoughts, and all of this can then improve your overall well-being, your mood, and that's what we're targeting, isn't it? Our sense of well-being. So you can use this approach for a treatment of disorders, and there's lots of good evidence for pretty much any disorder you can think of in psychiatry as well as in medicine. But you can also use it to advance the happiness goal. And so Dallas referred to positive psychology, positive psychiatry. These are newer burgeoning areas around the science of well-being, the science of happiness, resilience, and in particular, positive psychiatry is trying to bring that science to the population that's mentally unwell, as well as the general population. What does the science say promotes well-being and happiness in terms of our thoughts? Kind thoughts, generous thoughts, self-compassionate thoughts, gratitude, in addition to creating more time for us to spend with others through having affluence of time rather than time poverty, which is something a lot of us suffer from in academia and in generally in healthcare. And the idea of flow, which is a cognitive process of being present, not distracted by the many different bells and whistles and notifications, basically, and being able to absorb yourself completely like kids do when they play, in our workspace. If you want to know more about this, feel free to check out the Happiness Lab and Science of Wellbeing course that's now been enrolled by over 1 million people in the context of the teacher, Dr. Laurie Santos, making this free on Coursera in COVID. So lots of people are tuning into her course. So that was what we were talking about, cognitive. What about interpersonal? The idea that we are social beings. COVID has, people have really come to appreciate, I think, much more the degree to which we depend on one another, and find some proximity, some proxy of having like close personal contact when we're all missing our families. But at the end of the day, this relates to the importance of having somebody who's in your corner, someone you trust. So most of us are finding ways to continue those very vital types of relationships one way or the other. And the person who's in your life who has your back is the one that you've been turning to through the pandemic. These things matter to our well-being a great deal. And so we now know much more about the science of loneliness, and patients, with mental illness are at greater risk of this: social isolation, stigma, self-stigma, and health risks associated with loneliness are enormous, now known to be a similar magnitude to smoking and obesity. So these things matter. And in the longest study that we know of on resilience and looking at factors that predict well-being into late life, we now know that secure relationships measured at the age of 50 predicted well-being over the next 25 years more than any other factor. So this was a study, a famous study, comparing inner city Boston men from poor neighborhoods to Harvard sophomores, and followed them now for 3/4 of a century. What about behavioral factors that we can engage in? Well, this includes physical activity. We know that it's one of the best promoters of brain neuroplasticity across your lifespan. And it has also been shown through the Lancet report, that was a large meta-analysis, that it's really a significant protector against cognitive decline. So it's important for all kinds of things, avoiding falls, improving balance, but also our functioning and our mood state. And it's so important, and there's so much evidence now that it's included in national guidelines for the treatment of mood disorders, mild to moderate, depression for sure, level 1 evidence, and this was also shown in a Cochrane review. So the question is, how often are we able to actually help patients activate physical activity when they come to us with depression? That's an important question to ask, given the level of evidence for this. Now, what do we do with that in our day-to-day practice? People are coming looking for a pill with their mild to moderate depression, and you might turn around and say, well, actually, what you do is exercise. The patients will be very, very perplexed by that kind of prescribing. So what we have to think about how to apply this, and I'd be really interested to hear the discussion around this if people have had some experience and any success there. The other behavioral piece is not sort of activating yourself with exercise, but the opposite, the ability to draw on our natural nervous system's ability to relax. Every time you sit down to have a meal and digest your meal, or you get to sleep at night, you are depending on your relaxation response. And there are ways that we can learn to tap into that and to actually have more influence over our own nervous system. And a bunch of different things are listed here. And the use of these techniques really help people to get to sleep at night, have better quality sleep, manage stress better in the heat of the moment on difficult, stressful days. You can think of this as an optimal level of arousal. If you're too relaxed, you'll fall asleep. You don't want to do that when you're sitting at your desk at work. But if you're too hyper aroused and you're feeling too much, it's hard to function. It's hard to actually bring your full mind to a situation for problem solving. And it turns out to be very bad for your health over the long term. If we hope to get to sleep at night, if we hope to stay healthy with our nutrition, the ability to rest and digest is important. And there's a whole movement now around sort of mindful eating and slow cooking, that whole idea of actually slowing things down, relaxing, and more enjoying, Italian style, la vita dolce. So in summary, this comes out of the Boston Institute, but I think it's still very relevant in Canada. What makes us healthy turns out to be a lot of these kinds of health behaviors or health habits. Up to 50% of what makes us healthy is based on these lifestyle habits. And yet what we spend on being healthy is a fraction of that. 88% comes to medical services after people have developed problems. So, what do we do within the formal healthcare system to integrate that? What we have right now, I think, is a lot of really helpful resources. I think these are examples of organizations, materials that are attempting to close the gap that exists between what makes us healthy and what we actually provide in healthcare. So please look to those as resources. And I'm just going to touch on some resources that the CCSMH and Fountain of Health have been working on. The Fountain of Health is a KT organization to share, information about resilience and well-being, and uses these very minimal CBT approaches to help people activate their health behaviors in these various domains that are listed here. And some of those were ones that were just touched on regarding evidence-based. We also developed a behavioral toolkit and an app to assist clinicians to integrate more wellness promotion in the context of their day-to-day care. And with a grant from CABI, together with CCSMH, we piloted this, and our results across the country, with over 2,000 registered clinicians for their education and 800 using the tools in practice, what we found was using a brief 3-step approach that about 85% of patients experienced improvements in their well-being, and up to 90% completed the health goal that they set. So these are brief tools that you can use in your practice. If you're interested to learn more, there is a course that we offer twice a year. The next time, we're just finishing it now, and the next time will be in the fall. So if you would like to learn more about how to integrate the use of this approach for your own self and also in your practice, you're welcome to request registration. So you would just email us at info@fountainofhealth.ca and just say, 5-minute CBT course if you're interested. So yeah, I'm going to stop there and open it up for questions.